I'm going to start the PG Fishbowl session. So this is getting organized for the first time by Jharkhand Ophthalmological Society, and today is our episode 1. This is the brainchild of Dr. Shweta Walia, Chairperson Scientific Committee, Madhya Pradesh, and she agreed for being moderator of this session. The fishbowl training method is a structured collaborative learning technique where a small group inner circle discusses a topic, and while a larger group, that is the outer circle, observes and takes notes. It enables in-depth discussion, models active listening, and allows for large group participation without chaos. It is effective for complex subjects, debates, and skill building. And you all expert panelists know, because you all have been participating as expert panel. So we have with us Dr. Sunil Kumar, our JHOS ARC chairman, Dr. Rahul Prasad, Dr. Joint Secretary, Jharkhand Ophthalmological Society, Dr. BP Kashyap, the past president, Jharkhand Ophthalmological Society. Now over to Dr. Sunil to introduce the mastermind of this fishbowl, that is Dr. Shweta Walia. Over to Dr. Sunil.
Yeah, good evening to all. Yeah. So I welcome all in this fishbowl session. Introduce the moderator of today's session, Dr. Shweta Walia. So will you show the slide, introductory slide?
Yes, yes. Is it visible?
No, not yet.
I don't know what has happened.
Yeah. Now it is visible. Yeah. So Dr. Shweta Walia is a professor, MGM Medical College, Indore, and she is also the chairperson, Scientific Committee, MP State Ophthalmological Society, and she is the chairperson, Scientific Committee, OS, Central Zone Representative, OTSI, Central Zone Representative, IS, International Society of MICS, and she has more than 50 publications in national and international journals, and she has received so many awards, and she has innovated techniques of the sutureless, glueless SFI in 2016. So I welcome Dr. Shweta Walia ma'am for moderating the session of this fishbowl. And another moderator is Dr. Bharti Kashyap. We all know she needs no introduction. And
Yes.
we also have the expert panel for the today's fishbowl session. Dr. Suvina Narang, she is the professor of ophthalmology at GMCH Chandigarh. Dr. Suganeswari, she is the senior VR surgeon from Sankar Nethralaya, Chennai. We have with us Dr. Purna Chandra, consultant VR surgeon, Narayana Nethralaya, Bangalore. And Dr. Pratyusha Ganesh is the additional professor at AIMS Mangalagiri. So today we will have the two case presentation. The first presentation will be by Dr. Pragya Chouhan. She is the DNBS student, second year from the Kashyap Memorial Eye Hospital. And the second presentation will be by Dr. Irshad Khan. He is second year DNBS student from the Kashyap Memorial Hospital, Ranchi. So thank you.
So over to Dr. Rahul Prasad for just a one-liner introduction of the inner circle and the outer circle.
Yes, ma'am. So for our ma'am, for our inner circle participants, we have postgraduates from MGM Jamshedpur. We have postgraduates from TMH Jamshedpur, from Bhagwan Mahavir.
Please name them.
Yes, ma'am. Yes, ma'am. So from MGM Jamshedpur, we have got Dr. Amar Kumar, Dr. Mayank Naran, Dr. Vikas Thakur, Dr. Neha Chaudhary, and Dr. Nidhi Sharma. From TMH Jamshedpur, we have got Dr. Bhavya Chaudhary, Dr. Raksha Kumari, Dr. Richa Kumari, and Dr. Sana Afreen. Then from Bhagwan Mahavir Manipal Hospital, Ranchi, we have got Pooja Tanwar and Dr. Shreya Kaul. From Gandhinagar Hospital, CCL, we have got Dr. Lalita Priya ji. And from Bokaro General Hospital, we have got Dr. Nupur Gupta and Dr. Dushar Dhiman. That comprises the inner circle. For the outer circle, we have our own residents, Dr. Anamika and Dr. Vatsala. From Bokaro General Hospital, we have got Dr. Anamika Thakur and Dr. Ujjwal. From Gandhinagar, Dr. Gagandeep Singh Gulati from Kashyap Eye Hospital and Dr. Shubhan Singh from Kashyap Eye Memorial Hospital, Ranchi.
So thank you, Dr. Rahul, for introducing all the PGs from inner circle and outer circle. And today, maximum postgraduate students have joined. So before we invite Dr. Pragya Chouhan and Dr. Irshad Khan, I invite Dr. Shweta Walia for a brief introduction of the session from the mentor itself who has created it. So over to Dr. Shweta Walia before the starting of the presentation by Dr. Pragya and Dr. Irshad. Dr. Shweta, welcome.
Thank you, Dr. Bharti, for your kind words and adopting the technique that we were doing in MP state for past 2 years in Jharkhand. And we found that it is actually beneficial for the residents because they take part in active discussion. And also the listening skill of residents is improved by listening to the what others are saying. So the concept over here, Dr. Bharti has already told that it is basically for learning, where one presenter is there, will present a case. In this scenario, she'll be presenting case for 6 minutes. The residents of inner and outer circle will be actively listening to the case presentation. Then first turn will be that of inner circle, and they will discuss the topic, ask question from the presenter. And after all the participants of inner circle have asked question from the presenter, then it is the turn of outer circle. They will ask question if any particular thing is left behind, and they can also add their queries if they have any. And finally, after outer circle, it is the turn of our experts to give their final comments, or if they want to ask some question from the resident, from presenter, they can ask. So our experts, Dr. Subina Narang, Dr. Subneshwari, and Dr. Patyusha, they are all well versed with this
and Dr.
technique.
Purna.
So it is actually the three are already participating for past 3 years and have been experts in MP state programs. And Dr. Purna, I think it will be.
You think?
You'll also like this concept, and definitely you will add to this program, and we'll have a great learning from you as we had from your presentation on ERG EOG. So hope that everyone will enjoy this session, and it's
and
my
please
request.
Announce the cash prize.
Okay, ma'am, that you will announce the cash prize.
No, you have to select.
So I will not select. The experts will come up with the consensus for the best question from inner circle and one best question from the outer circle. So it is my request for the experts to take note who has asked the best question and come up with a consensus and announce the best question from inner circle and from the outer circle. And Dr. Bharti will announce the cash prize, what she is going to give to the residents.
We have kept, yes.
So I would also request all the residents to switch on their videos, and better if you can put your name so that we know who is asking the question for better interaction.
All residents, please.
So okay, all of you can switch off.
And please camera on.
So while Dr. Pragya will be presenting, you carefully listen to what she is presenting and be prepared with your questions, and the experts will announce the best question from inner and outer circle. So may I request Dr. Pragya to start sharing your screen?
Yes.
And yes, please. So you can make it slideshow.
Pragya, make a slideshow.
Right. So please start your presentation.
Good evening, everyone. This is Dr. Pragya Chouhan, a second-year resident from Kashyap Memorial Eye Hospital. I'm going to present a case of a 22-year-old unmarried male who presented to our OPD with diminution of vision, which was right in both eyes, but right eye more than left eye, and it was since childhood. The diminution of vision was gradual, painless, and progressive in nature, associated with nyctalopia. There was no history of pain, redness, floaters, or flashes of light. Also, there was no history of any other ocular trauma. No history of deafness was also present. Past history was not significant. Also, the family history was not significant. Although we could not get a proper pedigree, but the history the patient gave, according to that, I have generated this pedigree. He was the first one to be affected in the family. On general examination, patient was alert, conscious, and cooperative. Facies were normal, pallor, cyanosis, icterus, clubbing, edema was absent. In short, systemic examination was generally normal. On slit lamp examination, size of the pupil was 3 mm, circular in size, central. Reactions were present, both direct and consensual. RAPD was present in right eye, but it was absent in left eye. On applanation tonometry, IOP was 12 mm Hg in right eye and 14 in left eye. Visual acuity was hand movement close to face in right eye and 6/36 in left eye. Near vision could not be assessed and it was N/10 in left eye. Color vision could not be assessed in right eye, but it was affected in left eye. Ocular movements were full, free, and painless in all directions of gaze. Position of the eyeball and size of the eyeball was normal. Slit lamp examination, conjunctiva, cornea, lens, interior chamber, everything was normal in size, normal. We could not find any positive findings in the interior on the slit lamp examination. On posterior segment examination, media, there were no vitreous degeneration seen while doing indirect ophthalmoscopy. Size and shape of the disc were normal. A slight temporal pallor was noted in both the eyes, but margins were well delineated. Bony spicules were present around the macula and juxtamacular area. A mild arteriolar attenuation was also present. Investigations we did were ultra-wide fundus photo, OCT macula, and multifocal ERG. This is the ultra-wide fundus photo showing bony spicules which were more prominent in the macula and the juxtamacula and juxtapapillary area with a slight temporal disc pallor. This is the fundus photo. This is the OCT image showing symmetrical retinal thinning and photoreceptor layer disruption. We also tried to do multifocal ERG. Both eyes shows noisy waveforms and it was unreliable since the vision of the patient was very low. My provisional diagnosis for this case was asymmetrical inverse retinitis pigmentosa. Differentials could be choroidal dystrophy, cone dystrophy, post-inflammatory sequelae, retinitis punctata albicans. Summary. This is a case of a 22-year-old male who presented with DOP, right eye more than left eye, since childhood, with no systemic illness and no similar complaint in the family. On examination, BCVS was hand movement in right eye and 6/18 in left eye. Normal interior segment. On fundoscopy, both eyes showed bony spicules involving macula, juxtapapillary area, with slight temporal disc pallor and mild attenuation. Retinitis pigmentosa typically presents with night blindness and peripheral vision loss. But this is a case of inverse retinitis pigmentosa, which can affect central vision at an early stage. As of now, there are no treatment modalities available. Multiple research and advancements are underway. Currently, no treatment modalities. Photochromatic glasses can be given to the patient or trial of low vision aids can be given to the, but the most important is we should go for genetic test followed by genetic count. Recent advancements were gene therapy, prima, stem cell therapy, and CRISPR gene editing is also being tried. They are not like implemented anywhere. Thank you.
Thank you, Dr. Pragya, for such a wonderful presentation. And now the case is open for discussion. Hope the inner circle is ready. So who is going to start the discussion? Dr. Amar, can we have the question from your side?
Yes, ma'am. Good morning, good evening, everyone. My question is, what is the differentiate between ma'am said that there is a
your voice is not clear.
Voice is breaking.
hello. Am I audible?
Muffled.
Hello, am I audible?
Yes, you are better than earlier. Please be loud.
Ma'am, good evening, everyone. My question is about how to differentiate that the features shown in inverse retinitis pigmentosa and rod cone dystrophy. how to differentiate between these two?
How to differentiate inverse retinitis pigmentosa from
Cone dystrophy.
From rod
Rod
dystrophy.
cone dystrophy.
root cone dystrophy? See, there are many things. First of all, we can go for multifocal ERG. We can go for in cone dystrophy. Mainly the multifocal ERG we can go for.
Yes.
Yes, Dr. Amar, are you satisfied with the answer, or would you like to add to it or ask something else?
No, ma'am.
Okay. So you answered very well, Dr. Pragya. So from whom are we going to have the second question? Bhavya, Dr. Pooja, Dr. Lalita, who is going to ask?
I have a question.
Yes, please.
Good
go
evening,
ahead.
everyone. Good evening,
Dr.
everyone.
Yes.
Yes,
Please
ma'am.
introduce yourself.
My name is Dr. Shreya. I'm a second year DNB resident at Manipal, Ranchi. Dr. Pragya, my question is, how did it come up to you? Like, why is your first provisional like towards inherited disease? What acquired causes did you think of first? And like, for example, you very early on mentioned about the pedigree chart that you showed, like you tried to attempt drawing a pedigree chart. So what made you think more towards inherited? For example, as basic as vitamin A deficiency, was that on your mind first?
Vitamin A deficiency, mainly it is not that progressive. But the patient said that vision was progressively diminishing. And moreover, the fundus photos and the optus we show it, the kind of fundus photo we show it is more often a hereditary type of dystrophy. We are like supposedly some dystrophy is there. That is why we are pointing towards genetic thing.
Yeah.
So very good question, Dr. Shreya. Yes, you want to ask something else? Please go ahead.
Yes, ma'am. That is in a general question. As a PG, I have that curiosity. Like, since this case is being described as an atypical RP, but as they have mentioned in the case, we see two signs out of the three of the triad. So we have seen in this case, as Dr. Pragya mentioned, bony spicules were there, attenuation was also there, and slight temporal pallor also they've mentioned. So at what point do we actually call it atypical RP?
Because typical RP involves periphery first. It involves first periphery and then it involves center. But this is involving first the center, close to the macular area. That is why we are calling it
Yes, so
atypical.
on the basis of the pattern of diminution of the damage you have actually clinically you have noticed that.
Clinically.
Yeah, sure.
Very good,
Thank you.
Dr. Pragya. So from whom are we going to have the next question? Can we have it from Dr. Pooja, Dr. Lalita, Dr. Mayank? Anyone from inner circle? So I think you can stop sharing your screen so that we can have all the participants on the screen. Yes, please. Dr. Lalita, would you like to ask something? You can unmute yourself and ask, please.
So already Gandhinagar has asked.
Yes, she has to ask. Dr. Lalita, please proceed. Please. You are not audible. I think you are muted or you're not connected.
So one question should be asked from CCL, one from Bokaro, one from TMH.
So we can do that. We can do that, definitely.
Yes. One from Kashyap.
Ma'am, good evening, everyone.
Yes.
Dr. Priya, first year diploma ophthalmology from CCL Hospital.
Yes.
Ma'am, I just wanted to know the difference between the full field ERG and multifocal ERG, ma'am. Since I'm beginner,
Okay. Multifocal ERG mainly involves the center 30 to 40 degree. We are just observing the central part, macular part. Central 20 to 30 degree we are checking. Okay. And in full field ERG, we are checking for the whole retina. Since we have a disease in which the mainly macula and area close to macula was involved, so we did multifocal ERG. But when in case of retinitis pigmentosa, it is a case of periphery. In that case, we would like to do full field ERG.
Okay, ma'am. So even if we do multi-field ERG, will it be very helpful in RP, ma'am?
multi-field, are you trying to say
multifocal ERG?
Multifocal, it is good for atypical. Whenever any disease involving macula is there, then we will try to do multifocal.
Okay.
Anything related to central 30 to 40 degree, then multifocal is preferred.
Like Usher's syndrome, kind of syndromes, multifocal.
Usher's, but I mentioned that in Usher there is like sensory neural hearing loss was also there. So that is why I firstly said it was not there.
Okay. Thank you so much, ma'am.
Very good question, Dr. Lalita. Yes, Dr. Pooja, you wanted to ask something? Dr. Pooja Tanwar.
Good evening, everyone. My name is Dr. Pooja Tanwar, DNB first year from Manipal Hospital. It's just a curiosity from my side. I was just asking, as the typical RP and atypical RP, both are the inherited. And as ma'am said, Dr. Pragya ma'am said that there is no permanent treatment for both of the like typical and atypical. So like, how I can say that what was the main purpose of differentiating that it is the typical or atypical? Is it only because of the involvement on the clinical basis, or like there is something that they are differentiating on the basis of the treatment also?
See, mainly typical RP, there is many a times mutations were present. This is a case of sporadic thing. First time the patient came to us without any genetic involvement. In typical RP, usually mutation in rhodopsin gene. So we can try for that. We can do the genetic testing. If there is a rhodopsin gene mutation, we can go for treatment according to that.
Okay. So it's like basically I'm trying to say, asking that, okay, like a treatment modality is also different for typical and atypical.
But I'm not completely, but yes, of course, if typical RP is because of a genetic mutation, so of course treatment will differ according to.
Thank you.
Thank you.
I think we should ask the outer circle now. What do you say?
So we have two more over here, Dr. Nupur and Dr. Nidhi. Would you like to ask something, Dr. Nupur? From inner circle, we can move on to outer circle.
See, I am asking whether one person from Bokaro has asked or no. One person from Bokaro should ask. One person from TMH, they have asked, I think.
From TMH, they have asked. So, if
ma'am.
Yes, please. Yes. What's your name? Please introduce yourself.
Ma'am, I'm Dr. Neha Chaudhary from MGM. Jamshedpur. Ma'am, I want to ask how to differentiate like Stargardt's from inverse retinitis pigmentosa, as in both case central scotoma is seen. So how to differentiate that?
Two ways are there to differentiate Stargardt's from RP. First is the fundus. Fundus will be different. In Stargardt's, we will get different kind of a fundus image. We will not get this type of a bony spicules or disc pallor. And second is ERG. Through ERG, we can also differentiate Stargardt's and retinitis.
What findings are that we see in ERG?
Stargardt's is more often a road dystrophy, and my case is more often a cone dystrophy. So in cone, that is the main difference. For Stargardt's, we will go for full field ERG because we are looking for a cone thing, and here we are looking for a rod thing. In my case, we are looking for a cone thing.
Okay. So the best part of fishbowl technique is that once your turn comes, then only you can ask the question. So once all the inner circle is complete, we'll move on to the outer circle and then to the experts, and we'll definitely like to take the input of Dr. Poon Chandra.
Yes.
I just wanted to ask Shweta ma'am one thing. Are you noting down the question, because there are so many wrong questions, so many wrong answers? So later
I'm noting down all the questions.
You can intervene. What you say? Because
thank you
there
so
are so many wrong question answer, whatever.
Yes, I'm writing it down.
Thank you so much.
So let's move to the outer circle. Dr. Anamika Chaudhary, who is...
Yes, ma'am.
Yes, please.
Yes, ma'am.
For your turn, please ask your question.
Yeah, first of all, Dr. Pragya, it was a very nice case presentation. I would just like to ask that what was the grade of RAPD, as you mentioned that RAPD was present, And secondly, was there any systemic examinations which were conducted on the patients? Because we have seen that in some studies, inverse retinitis pigmentosa has been found to be associated with, first of all, you said sensory neural hearing lobe is not there. Nice, and some also gynec disorders. So the systemic examinations were ruled out, and what was the grade of RAPD and why RAPD was there? So
systemic examination was ruled out. That is why I mentioned systemic history was normal. Grade of RAPD, I just forgot to mention in the PPT.
it's okay. It's okay. Thank you so much.
So there is another Anamika also over here, Anamika Thakur. Would you like to ask the question or?
Gagandeep.
Yes, Dr.
Shubham.
Gagandeep.
I want to ask, good evening, everyone.
Yes, please. Yes, please.
Myself, Dr. Anamika Thakur from Mokaro General Hospital. My question is that how does multifocal ERG help in monitoring progression?
How does multifocal, you are specific to this case or you are asking in general?
General case. General and specific to this case
In
also.
this case, the multifocal ERG was not reliable because the vision was very low. Multifocal ERG is reliable when vision is more than 6/16. In my case, multifocal ERG was not reliable. So we cannot use this for disease monitoring.
Okay.
Thank you, Dr. Anamika. Dr. Gagandeep, would you like to ask some question?
Not yet, ma'am. No. Thank you.
Gagandeep, Shubham, Neeraj.
Dr. Vatsala, she was active earlier. Please, if you would like.
Good evening, everybody. First of all, Pragya, it was a very great presentation, and also you answered most of the questions in a very nice manner. I just have two basic questions. So, firstly, you said that the pupil size was 3 millimeter. I just wanted to ask, how did you measure the pupil size? Because if you would measure it with a torchlight, the pupil would constrict. So the normal pupil size could not be measured by torchlight. And the second question is dorzolamide topical dorzolamide is of any use in inverse retinitis pigmentosa?
Ma'am, first of all, I think whenever there is a edema in OCT, then we can go for oral carbonic anhydrase inhibitors, not for the topical ones. And what you're asking about the pupil size, I just wrote in like the normal one. Matlab, it's not like how I measured it somehow.
So basically, there's a pupillometer by which have a small circles. Every circle has a size, so you can compare it with the size.
Yes, ma'am.
Yeah, thank you.
Okay.
So, anyone left from outer circle who would like to ask something, or we move on to the experts because we have also one more presentation to go.
Yes, move to the I think to the experts.
Okay. So let's have the inputs of our experts. So who is going to give the input? Dr. Subina, would you like to give your expert comment? Dr. Sugneshwari?
Yeah, actually, it's a wonderful the way of, the whole thing, how it got conducted was very nice. So I enjoyed the flow of the thing. So most importantly, like to say, like few of the questions which was asked by, certain people, like how do you differentiate? Why do you think in terms of this is an inherited dystrophy, and why not that it could be an infectious etiology? Or could it be any other inflammatory pathology? Those differentiation, that is something really important. But my only thing is, was there an ERG done in this patient?
Sorry, ma'am, why ERG was done?
No, was an ERG done in this patient? Because I think I missed on that.
Multifocal ERG, ma'am, was done, but it was not.
No, I'm asking about full field ERG.
No, ma'am, full field ERG was not done.
Because that is the most important test if we are talking about. One is a full field ERG and another should be a field examination.
Yes.
Was a field. So these two are relevant if you are talking about an inherited retinal diseases.
Okay,
You
ma'am.
know, because without that, to draw conclusions, and usually if a multifocal ERG has to be done, you cannot do it without a full-field ERG. You
Yes,
should have a full-field, and then after that only you try to do a multifocal ERG. And another thing also, what was the color vision in your patient? Because the left eye seemed to be having 6/18 vision.
Ma'am,
So what
color vision,
color vision?
we did color vision, it was affected.
No, affected means you need to tell what is the, how many number of plates, what is the involvement.
Ma'am, it
Because
was
affected, not affected is not the answer. If you are telling about color vision, you need to tell what is the modality that was used for identifying the color vision defect. And if you are using Ishihara, what is the number of plates that has been defective. So all these things you need to kind of tell, because that is most important when you are talking about, you know, inherited retinal diseases. That is predominantly mandatory.
Yes, ma'am.
And yet another point is, if your fundus photograph, if we kind of see, the blood vessels weren't that much attenuated when we see because you had shown one fundus photograph which was showing only the posterior pole, and another one was an optos image. So in an optos image, it is very difficult to probably, you know, sometimes it becomes difficult to talk about the caliber of the blood vessels itself, because it is a wide field image, you know, you really can't make out the caliber. So unless and until you take a posterior pole where you would like to really appreciate the blood vessel caliber. Because if you see your fundus photograph itself, that was not showing an attenuated vessel, and you kind of had more of pigmentation which was on the posterior pole. So my personal take would be that an electroretinogram is mandatory before we kind of even you know, decide about what we are talking about. Because if I am going to tell you your patient is probably having a chirpy, which is a grouped chirpy, how will you defend it? Congenital hypertrophic retinal pigment epithelium. You tend to have hyperplasia everywhere. It's a grouped chirpy. So if I say grouped chirpy, that again will have a lot of pigmentations. How will you defend to say that, yes, this is not?
Ma'am, just by ERG.
Yeah, so that is what I think it is pretty crucial that we need to have these things. Yeah, when we present a case, we have to have compulsorily all the investigations that is necessary for the case.
Yes, ma'am.
Okay, yeah.
Yes, ma'am.
Thank you. Otherwise, it was very nice discussion actually.
Yes, ma'am.
Thank you, Padmeshwari. Dr. Purna, please.
Okay, fine. Give me all fine. First of all, congratulations, Pragya. It's not easy to present a retinal dystrophy case, that to an atypical case,
Yes,
These are the kind of cases even when the retina specialist struggle to, zero in on. So still we can go on discussing. So excellent attempt. So most important thing is the way you have worked up the case, taking a proper history, drawing a pedigree and all that. So basically, when it comes to inherited retinal dystrophies, the first thing is you should be able to differentiate whether it's a treatable condition or a non-treatable condition. Okay, you should not miss a treatable condition and label it as a dystrophy. Once you label it as a dystrophy, 90% of your job is done. So in 10%, you need to differentiate further. The reason being, you need to explain the prognosis. I think there is no treatment. Somebody was asking, because both are there, what will you do and all that. So, so the way the patient is going to choose his career, the way he's going to handle routine things, okay, what he's going to plan for the future, everything depends on the kind of prognosis you have. And all retinal dystrophies may not have the same prognosis.
Yes,
that is very important. And also this is extremely important because I know I have many RP patients who are cab drivers. They tell sir, मैं चले तो रात में बनाना, and it's our responsibility to guide them. As a doctors, we treat patient, we diagnose, we do surgeries and all that, which is a very easy thing. But the toughest situation is when there is no treatment. Okay?
Yes,
because it is not only a burden for the patient, it's also for the family members. The way you counsel them, pinpoint, that becomes extremely important. That is one thing you need to prognosticate by pinpointing the diagnosis.
Yes, sir.
The second important thing is the awareness about genetic testing, which you already mentioned. It's also important that we should stop this transmitting to the next generation. Okay. You need to give them the genetic counseling. There are many methods to do that now. You can go for embryo selection, prenatal diagnosis. we can do amniocentesis, CVS and all that. Amniocentesis is more than enough. CVS may not be all the time. That is one thing. And
Yes.
regarding ERG and why it's not acquired, or why it's an may genetic disorder. If you look at the fundus photograph, first thing is it's very similar. Okay, so
Yes,
that
sir.
right on the full photograph, that is very in favor and early onset of disease. Okay, so that is. And regarding broad cone dystrophy and RP, somebody was asking. See, RP is also nothing but it's a type of broad cone dystrophy. Okay, broad cone dystrophies are nothing but a group of disorder where the degeneration starts in the periphery, involving the rod predominant area, then progress to the center, eventually involve the macula like that. In your case, atypical thing was the macula was involved. This is
Yes,
not the
sir.
case in a case of typical RP.
Hmm.
So once the macula is, see, the thing is, these are all the older terminologies which have been used, like RP, inverse RP, RP, giant pigmentosa. So what is the latest thing what we use for inherited retinal dystrophies? We always want to do a genetic testing and label with the mutation is possible. Okay, so that's
Yes,
your
sir.
final diagnosis. Okay, so and
Yes,
it could
sir.
be your case could be a choroidal dystrophy also. If you look at as someone was pointing out, there is not that much of a gross arterial attenuation, there's not much of a vaccipala which is not present. Okay, some of the choroidal
Yes.
dystrophies also can present like this. And to answer that vitamin A related question, see, vitamin A deficiency will not have any structural changes. Okay? There won't be this much of degenerative changes.
Yes, sir.
Most of the patients who are chronic alcoholics with irritable bowel syndrome, inflammatory bowel syndrome, present and all that, initial stage they will have a normal appearing fundus. Only
Normal.
thing what can pick up is ERG. Okay, and we can supplement it, and it will have a will have a it can be reversed. The changes can be reversed. Okay? And regarding fulfilled ERG, see, ERG is something where we are not able to understand things structurally. We are seeing something. If you are not able to understand, then you go for the ERG. Otherwise, CRG is not available everywhere, right? Not tell
Yes.
like you have to. Of course, for the case presentation, it's good that you have everything. But if something is very typical and all that, you're diagnosing it and all that, unless it's going to add, diagnostic or prognostic value, it's not a must. Okay? Like for example, in Stargardt disease, somebody was asking, ERG can have a prognostic value. Case like early Stargardts, the fulfilled ERG can be normal. That means the disease is limited to the macula, in which the prognosis is good. Both bones and rods are affected, the prognosis is bad. And this case can be a differential diagnosis for Stargardts. The reason being, when a very advanced case of Stargardts can mimic RP. Early stage, you will have beaten bronze appearance and all that. In advanced stage, when there is a degeneration is quite extensive, you can have these kind of bone speckle pigmentation and all that. So basically, to summarize, hope I have covered all the questions. In case if I missed, you can please ask me again. So to summarize, it's very important to diagnose and not to mislabel this treatable condition as dystrophy. Next, to prognosticate, do a deeper phenotyping by doing an autofluorescence, OCT, ERG, and genetics. Should put everything together, then counsel the patient. And you should never forget to send them for a visual rehabilitation. That is extremely important. Treatment management doesn't mean that you do laser, surgery, injection, and all that. Because visual rehabilitation becomes extremely important. I have patients who are doing really well once you tell them what are their limitations, what should be done, and all that. It's a very tricky situation. Otherwise, in Indian context, most of the time, they'll be under a lot of pressure, and acquired blindness is not an easy thing to handle. So, but if you counsel them well, if you tell them what they should do, what they should avoid, the quality of life can definitely. Okay?
Yes.
Hope I've answered. So please,
Thank
if I
you.
missed anything, please you can ask me.
All the points have been well taken up, and I
One
think
thing I would just like to say, yeah, everything is well covered. One thing I was wanting to make a point is like you took very nice history of hearing loss. That's it. But once you should not miss something which is a treatable cause of retinitis pigmentosa, especially in atypical cases. So do have phytanic acid deficiency, I mean, refsum disease in mind, and A beta lipoproteinemia. So history regarding this should also be taken from the patient once you are dealing with the case of retinitis pigmentosa.
Yes, ma'am.
And I will ask Dr. Now, because he's the electrophysiology expert, to pick up one person from the inner circle or outer circle, one person who asked the best question.
I think the person who asked
Question was
how
the
to differentiate between the Stargardts and this.
yes.
Sorry, I don't remember that
I
person.
think
That
it is
was quite
from someone
tricky and
who asked
That
this.
was Neha Chaudhary.
Neha
Outer
Chaudhary.
cycle.
Outer
Inner,
circle.
yeah.
inner
Neha
circle,
some
inner circle. Yes, ma'am. Yes, Neha.
Zoom user. Okay,
Neha
so
Chaudhary.
Yes, ma'am. Yes,
From
ma'am.
which Neha Chaudhary is from where?
Thank you, ma'am.
Neha Chaudhary is from Jamshedpur, MGM.
Yes, ma'am. Yes, ma'am.
So you have to come on 18th for the collection of the prize.
Okay. Thank you.
And there for LDP also we had two winners. One is local from RIMS, Dr. Anamika, and another is Ujwal. Ujwal is also from which place? Bokaro. Okay, so your question was the best, and you
One from outer circle, Dr. Bharti. One from outer circle, she is from inner circle. One
अभी
one
हमारे
from
पास
outer.
एक ही है for एक ही है जो one is for
Okay, Dr. Bharti. Can we move on to next presentation?
yes, Dr. Irshad.
Yes,
Dr.
ma'am.
Irshad,
Good evening.
please share your screen. And we would like to have Dr. Pratyusha's comment on Irshad's presentation on the first when we are taking expert comments. Please, Dr. Pratyusha, please be ready.
Sure, Dr. Shweta.
Yes, Dr. Irshad, please start.
Yes, ma'am. Good evening, everyone. Myself, Dr. Irshad. I'm here to present a tale of rare retinal vasculitis. So let's start the case. We have a 16-year-old female who was immunocompetent, presented in a OPD with a complaint of diminution of vision in right eye since 2 weeks. Her diminution of vision was in right eye was gradual, and her visual acuity in right eye was 6/60, and left eye was perfectly normal, 6/6. We asked about the past history. She had a history of fever 1 week back, and she took medicine for the same, and her family history was not significant. We did general examination. Patient was alert, conscious, oriented with time, place, and person. Her pellar, sinus, icterus, clubbing, everything was absent. No history of weight loss. Her vitals was within normal limit. And one positive finding was she had her body temperature was raised. On ocular examination, her pupil size shape was normal. Ocular movement was free, full free and painless. RAPD was absent. Intraocular pressure was within normal limit, and her color vision was within normal limit. We did slit lamp examination. On slit lamp examination, lid, conjunctiva, everything was normal. Anterior chamber was quiet. Cornea was clear. Lens was clear. Iris was within normal limit. On fundus examination, vitritis was present and perivascular sheathing of retinal vessels. Then we did fundus photographic imaging. Here we can see the diffuse translucent perivascular sheeting of retinal vessels, which actually looks like a frost tree branch covered with the snow. Actually, this is what look like a frost tree branch, which looks like a covered with the snow. Here we can see the fundus photo. Then her left eye was within normal limit. Then we did a optical coherence tomography OCT. Here we can see the macular edema in right eye, and her left eye was within normal limit. So this was the main reason of her reduced vision. Then we did lab investigation to rule out other inflammatory and systemic illness like CBC, SR, CRP, torch, cytomegalovirus, ANA. To rule out TB, we did quantiferon gold. Then we did chest X-ray. One of our positive finding was serum cytomegalovirus IgM was positive. Lymphocytes, CRP, and ESR was raised. So our differential diagnosis are these are our differential diagnosis. Cytomegalovirus, acute retinal necrosis, and toxoplasmosis. Let us rule out one by one our differential diagnosis. First, cytomegalovirus. Cytomegalovirus mainly occur in immunocompromised patient, and it is associated with necrotizing retinitis and hemorrhages. But in our case, these kind of observations findings are not visible. And also in cytomegalovirus retinal, we see a classical pizza pie appearance, which was absent in our case. So cytomegalovirus is ruled out. Next is acute retinal necrosis. In acute retinal necrosis, there we here we can see severe vitritis and severe pain, which actually leads to RD. And and mostly here the peripheral, we can see the peripheral necrotizing retinitis in this case. And these findings are absent in our case. So acute retinal necrosis are ruled out. Next is toxoplasmosis. First history we asked about do you have a pet or cat in your home, but it was no negative finding was there. But in toxoplasmosis, focal lesions are present, and in our case, diffuse lesion was present. And in toxoplasmosis, headlight in fog classical appearance present, but here these kind of findings are not visible. So toxoplasmosis is ruled out. Next is Behçet disease. In Behçet disease, it is also kind of retinal vasculitis, but it is associated with oral and genital ulcers. And in our patient, these kind of findings are absent. So, and uh, uh, in Behçet disease, vasculitis is occlusive, but in our case, it is uniform and diffuse. So, Behçet disease is ruled out. Next is Eales disease. Most important Eales disease. In Eales disease, mostly peripheral retina is involved, and here in our case, central part of retina is involved, and in Eales disease, there we can see segmental involvement. But in our case, there is diffuse involvement, and Eales disease is chronic, but our patient is complaining about a vision loss, which is acute case. So so Eales disease is ruled out. Next is ocular tuberculosis. As ocular tuberculosis is also segmental and patchy appearance is seen on fundus, but in our case, diffuse findings is observed. And also our TB interferon is negative. So ocular TB is also ruled out. So we come to a provisional diagnosis: unilateral frost bronchitis, which is secondary to cytomegalovirus, which is the most common cause of frost bronchitis due to cytomegalovirus infection. So treatment. After confirming the cytomegalovirus, we started antiviral therapy, then followed by later oral corticosteroid therapy to reduce the edema, along with symptomatic treatment. So patient came back for follow-up after 15 days. Here we can see the fundus photo, right? Here we can see the resolved frost bronchitis, and her visual acuity significantly improved from 6/6 to 6/9. And her left eye was still uninvolved and with a normal limit. And we did OCT. Here we can see the reduced macular edema, and left eye was still with a normal limit. So, now this is a summary of my case. We have a 16-year-old immunocompetent female with DOV in right eye. We did a fundus examination, and we saw perivascular sheathing of retinal vessels, which of retinal arteries and veins, which looks like Foch branch, which is suggestive of Foch branch angiitis. We did OCT central retina, here where we saw macular edema in right eye only. Then post laboratory confirmation of CMV, and we started systemic antiviral. Later, subsequent oral corticosteroid therapy was also given. Post treatment, we saw fundus photograph which show resolved Foch bronchitis and suggestive of Foch bronchitis and decreased macular edema. So so our final finding is most important thing, her visual acuity improved from 660 to 6/9 on follow-up. So conclusion: Foch bronchitis in adolescent can occur secondary to cytomegalovirus, which is the most common cause, despite being immunocompetent. And Foch bronchitis is mostly bilateral, but in our case, this is unilateral, which makes this case unique. So in this case was unilateral presentation, and Foch bronchitis also signals possible systemic disease. So we have to rule all the systemic disease by doing lab work. So early diagnosis and timely treatment are critical for favorable systemic and visual outcome. These are my references from standard textbooks and some article. Thank you.
Thank you, Dr. Irshad, for a wonderful presentation. And now the case is open for discussion, and we can have participants from inner circle to question Dr. Irshad. So who is going to start the discussion? I could see Dr. Mayank has joined from inner circle. Dr. Mayank, you have not asked in the previous round. Would you like to ask some question from Dr. Irshad? Dr. Mayank, yes, please. You can switch on your video so that we can have a better interaction. Yes, please. Please ask your question.
Hello, ma'am. Mindset from MGM Jamshedpur. I want to ask if we can think of HIV retinopathy as a differential diagnosis in this case.
Yes, sir, we can think, but we have ruled out by doing laboratory investigation. We have done HIV, HBsAg, everything. Everything was not negative.
Okay. Anyone else would like to ask some question?
Good morning, everyone.
Yes, Amar. Yes, please.
Amar from MGM Jamshedpur. I want to know that what are the key imaging features on FFA to distinguish between frosted branch angiitis from Eales disease?
Yes, sir. So in FFA, we will see the diffuse vascular leakage in both arteries and vein. But in Eales disease, only veins are involved. And also in Eales disease, we will see the extensive CNP areas, which are absent in, which are rare in FBA. So the takeaway point is in FBA, both arteries and veins are involved, but in Eales disease, only veins are involved.
Okay, thank you.
Thank you, Dr. Amar. So anyone else who would like to ask the question?
Ma'am, hello. I just
Yes,
wanted to
ma'am.
ask few questions.
Yes, please.
Why veins are prominently involved in arteries in this disease, ma'am, FPA, and what is the reason behind it? And I also wanted to know about the macular complications involved in this disease. So these are the questions.
Ma'am, due to inflammation of retinal vessels, there is damage to endothelium. And due to this damage, fluid leakage, there is leakage of fluid, and due to increased permeability, and there is leakage of fluid, this causes macular edema. And this is the main cause of decrease in vision.
Okay.
And another question is, ma'am, retinal veins are
Why
inner.
veins are prominently involved than arteries in this disease?
Arteries are thick muscular walls, and
Okay,
they are
fine.
more resistant to inflammation. But veins are less smooth and less elastic tissue. That's why veins are more involved.
Okay. And which systemic diseases should be ruled out in this case? What are the other systemic diseases more prominent?
Systemic diseases like CMV, HIV, HBsAg, and other sarcoidosis. Then all the infectious cause like SLE, then
Behçet's disease, SLE.
Behçet's disease. We have ruled out by because she was not having any kind of oral or genital ulcer.
Okay, thank you.
Okay, Dr. Lalita, let's move on to the outer circle. Who would like to ask the question? Dr. Gagandeep, are you ready with your question?
Yes, ma'am. As we
Yes,
see,
please.
the CNP areas are often limited, although the sheathing, sheathing in frosted brown angiitis is quite extensive. So why is that? Why is CNP area still limited?
Sorry?
CNP areas, why is it so limited? While the sheathing is quite extensive, it's a diffuse disease. Why is the CNP area limited?
Like in Eales disease, you will see the extensive CNP area because then mostly veins are involved. But here, both artery and veins are involved.
No, I understand that, but it's because it's not an occlusive disease, right?
It is a perivascular inflammation.
Perivascular inflammation.
You
That's
can
why there's
sheathing
no
and leakage.
obstruction of the flow itself.
There is no obstruction because it is perivascular disease, and perivascular means vein vessels के बाहर, not under. So it's not occlusive. It is perivascular
And
disease.
we do not see a large amount of CNPs areas.
Yeah.
So very good, Dr. Irshad, for wonderfully answering the questions. Anyone from outer circle? Dr. Vatsala, Ujla, Shubham, Anamika, you would like to ask some question?
Dr. Irshad, first
Yes,
of all, a very nice presentation. I just wanted to ask 2-3 basic questions. Like the first one is, which systemic antiviral did you start, and what was the dosing of the same? And secondly, yeah, you can go ahead.
Ma'am, we have two options. Mostly for CMV, we use ganciclovir and valganciclovir. Valganciclovir is a product of ganciclovir. But here the patient is stable. That's why we use valganciclovir, whose dosage is 900 mg per day. So we have a tablet in market, 400 mg. So we have given 400 mg BD.
Okay. My second question is, why was the steroid started later, as in a week later?
Ma'am, if we will start it earlier, it will worsen the condition because the patient is already having a cytomegalovirus infection. So she is a little bit thoda sa immunocompromised. So it will worsen the condition. That's why we have given under the cover of antiviral. After 7 days, we have started the steroid.
And the last question is, what is the basic pathophysiology that the vessels look frosted? I mean, why is it called frosted?
Ma'am, because it is a perivascular disease due to accumulation of exudates around the vessels. It is looking like a branch where many snow are getting accumulated.
Oh, thank you and all the best.
Thank you, ma'am.
And Dr. Irshad, I would just like to add and ask you that what are the other causes which can lead to this condition? And why was the more the inclination towards the infective cause and not an occlusive cause? Because sheathing is there, and why? What are the other causes which can cause a similar picture in the retina? And why was your diagnosis more towards an infective cause? And how could you differentiate it from an occlusive disease?
Ma'am, we can differentiate by using FFA, and we have done,
clinically, any science, clinically, FFA is of course there, but clinically, by just looking at the fundus, is there any way in which we can differentiate it?
We can see the like sheathing around the vessels, and
okay.
And clinically, ma'am, can you repeat the question?
Yeah, how can you differentiate it clinically from an occlusive disease? Not by using FFA, just by say looking at the fundus, or by looking at the anterior segment examinations or any other fundus examination or systemic examinations which you have done.
Ma'am, other systemic examination, like we have asked everything about like any kind of rash or loss of body weight, and that will rule other the causes. Like we have we have asked about malar rash or other rash to rule out SLE. We have asked about genital ulcer or oral ulcer to rule out Behçet disease, and we have asked about the recent loss of body weight to rule out HIV or tuberculosis. And also on the
okay.
Yes, ma'am.
Thank you.
So let's see what experts have to add to Irshad's presentation. Dr. Pratyusha?
Dr. Irshad, a very good attempt. I think you tried your best, in this. A couple of things. You think really CMV treatment was necessary in this patient?
Yes, because IgM was positive, not IgG. So she was having current active infection.
So just serum IgM coming positive in CMV is sufficient to say that the patient is having infection?
Ma'am, we could have done like a PCR of AC-TAP that will confirm a diagnosis, but we haven't done that.
So there are also other ability tests that you have to do before you can confirm that this is CMV related. And the second thing is that somewhere you said patient is immunocompetent, and then you said she's probably a little bit immunosuppressed. So the main thing you need to differentiate. Tell me.
Like she was currently having fever and other thing. That's why, and she was like not severe, like she was comfortable at home. Everything. The infection was not severe. That is why we didn't start IV, because she was not admitted. That's
so what did you give? You gave oral
medication. Yes.
Okay. So the main thing is that you need to be very clear whether your patient is immunosuppressed or immunocompetent. Okay. So when you're talking about immunosuppressed and CMV infection, it is mainly the CMV virus infecting the endothelial cells of the retinal veins. But when you're talking in an immunocompetent person, it's mostly we are talking about an immune complex mediated disease. So these are two entirely different things. So it's not very easy to manage this frosted branch angiitis related to CMV in a HIV patient as against an immunocompetent patient. So it's an immunocompetent, you give steroids and you see an excellent response in these frosted branch angiitis patients, right? So you need to be
Yes,
very
ma'am.
clear what you are dealing with, right? You are doing so many investigations like CBC, peripheral smear, and all these things are basically to see what is the immune status of the patient. You can see the WBC counts, the lymphocyte counts, and other things. So what
Yes,
I want to
ma'am.
tell you is that basically when your uveitis is a very complex disease, many a times you get positive results which don't make any sense. Sometimes you get results you don't get results positive when you're expecting that a certain disease is going to cause this particular form of uveitis. Okay, so you need to be very patient, and very important is to have a good clinical acumen. Okay, so in this condition, for example, this process, you had so many differential diagnoses, right? So you could have usually sarcoidosis, what you have put in one of your differentials, usually presents with periphlebitis. Okay, and also you see in those peripheral regions, you see some snowballs and some granulomas and other things in sarcoidosis, which usually you don't see when it is this viral related thing. And syphilis, what you put, basically there it's more of a periarteritis. You're talking about SLE. SLE most commonly is presents with hemorrhages, cotton wool spots, and capillary non-perfusion areas, new vessels, and these things, right? Again, tuberculosis, it produces very focal perivascular venous sheathing. It's not like these diffuse and a long lens of perivascular sheathing which you're seeing from the posterior pole going all the way up to the mid periphery and beyond. So a good clinical examination itself will help you rule out a lot of diagnosis. Okay, and every investigation that comes positive in uveitis, you don't have to jump in and make it the etiology of that uveitis. That's what I'm trying to say. Okay.
Okay, ma'am. Yes, ma'am.
Thank you, Dr. Pratyusha. And since we are running out of time, we can, I think, since we had a good discussion, can I request Dr. Sugneshwari to announce the best question from all the questions that were put by the inner and outer circle? Dr.
Yeah,
Sugneshwari?
it was actually a wonderful discussion. Only one thing I just wanted to say was like syphilis is one thing which Dr. Pratyusha pointed out. It was a good point. But yet another thing I would like to tell is, most importantly, you may you did not have a single hemorrhage in the retina.
Yes,
So that
ma'am.
itself rules out that you probably had any event of a retinitis in your patient. So what you probably had was only an immune mediated response to a fever, because she is a young girl. She's a 16-year-old girl. So in a 16-year-old girl, if you get a response like this, if you are thinking in terms of a CME, you could ask for a urine quantitative PCR, where you can quantify the number of copies that is there. If not an aqueous, you can even do, because if she had had a systemic CMV, she will 100% be excreting the virus also. So you can do what is called as copy number. And the second thing is, an infectious disease consultant has to be he or she has to be taken into this one cross consultation. Without that, starting a patient on acyclovir is not a good idea, because see, one thing is a CMV will not melt away within 15 days. What you saw in the patient was within 15 days, there was no clue on the fundus, meaning the whole thing has melted. It's become a normal fundus. It has become a 6/9 vision. And your patient had a macular edema. So which also suggests that she was very highly immunocompetent. And what she was throwing was, because you said there was a history of fever for that girl, her body temperature was high. So she must have had an episode wherein she had reacted. So most likely these patients respond only to steroids itself. Oral steroids is most important. And yet another thing also, a bacterial cause also can cause this kind. You can also have, see, for instance, you can go through the article on RCBR, which I published. If you put my name, you will see an FBA, post-intravitreal injection, who had a branch retinal vein occlusion and then had an intravitreal injection. She developed an FBA. So these are certain things which are post-infective. Since, of course, post-injection, she had an infection to Streptococcus. So you can have these kind of entities also, which could camouflage your picture. So a CMV has to be treated only if it is proven a CMV, not otherwise. Because otherwise you kind of brand them and then they will be on, because CMV retinitis treatment is a prolonged course. And for a 16-year-old, we have to be very, very judgmental. Now to the question, who has given the best question is Dr. Gagandeep, who had asked on how do you, why was there an extensive sheathing and why is the CNP area is limited? I think his question is very valid in the context of this particular case. So I would feel that Dr. Gagandeep deserves the award for this one. Yes.
Thank you, ma'am.
Congratulations,
Thank you so much.
Dr. Gagandeep, and I must appreciate all the experts for such excellent guidance and such clarity of thoughts that they have shared during the session, and it is beneficial to each one of us. The mentors are also over here. We can see Dr. Sophia Ahmed over here, Dr. Rahul, and all sitting late night just listening the discussion. I must thank everyone, and special thanks to Dr. Bharti. Over to you, Dr. Bharti, for further moderation. Dr. Bharti.
Can I ask a question to Dr. Purnachand regarding ERG?
Yes, please, Dr. Sophia, you can. Dr. Purna is here.
So, while doing ERG, if the patient is uncooperative, can the results be reliable?
So you are starting discussion. So did you pick up the best discussion from Dr. Irshad's session?
So it was Dr. Gagandeep. Dr. Subrameshwari announced that
Okay.
Dr. Gagandeep.
Actually, I was discussing some about midterm conference. There is a lot of lot going. Yes. Okay.
It's okay, ma'am.
So we are organizing team na. So there was a lot of things going on. I was just reading. Okay.
So I had a question for Dr. Purnachand.
There are a lot of discussions for Dr. Purna, for Dr. Signeshwari, yes. And I can see Dr. also.
Regarding ERG, if the patient is uncooperative, will the results of ERG be reliable? Because most of the time, this is an objective test, and what the patients see that, like we have patients of unexplained visual loss. Everything is normal, fundus is normal, everything is normal. So we get an ERG done. So if the patient is not cooperating at that time, will the result be reliable for the patient?
So if the patient is not cooperative, it can definitely, the results can get affected. So, the ERG, the basic thing, the moment you start interpreting the waveforms, is always, I mean, it's kind of, taken for granted that ERG is being done in an ideal situation, following ISAF standard, and the patient was cooperative and all that. But the situation what you are telling, it is possible in children and also patient who are malignant.
Yes.
So
most of the malignant patients, they don't fix it.
So in these two cases, it's very tricky. Your ERG technician has to be intelligent to make them so cooperative. This thing. So, hello. Can you hear me?
Actually, Dr. Bharti is speaking. Yes, go. Please carry.
Yeah. So the thing is, what I was trying to tell is the technician has to be intelligent. First, if it's a children, to make them really cooperative, you can make them, show them the images of other children getting examined.
Yes, yes.
And also there are some shoulder spins which are available so that they don't remove the electrodes. So that is one thing. And in case of malingering patients, it's easy. I mean, basically when you're giving a stimulus, make sure that the patient has to see. Even if the patient sees once either the flash stimulus or a pattern, it will give us the recording. Okay. So the pattern.
Flash ERG is better for them.
Yes, flash ERG is better. The pattern ERG can be fake. For example, if you're giving a pattern, if the patient is not concentrating, still you can get an abnormal value. In that way, so there is a system to monitor. You're doing an ERG, there is a camera which gets displayed, which will, shows where the patient is. Once the patient is looking, even if it's not concentrating, the moment the light falls or the image falls on the retina, you'll get an recordings. Okay. So that becomes little easier, when it comes to picking. Malingering is very easy. Most of the time when you do the malingering test, you'll get
because many of our patients are malingering because it is an industrial hospital, so we have to refer them. So it comes in the comment that patient was not cooperative. So it is difficult to interpret those findings also at that time.
If the patient is not cooperative, most of the time it's malingering.
Yes.
And why will a patient who has a genuine problem will not cooperate? I mean, I'm talking about the adult patient. So the fact that it's not cooperating, it's not able to see. If you are 90% sure that it's a malingering. Okay. So unless patient has, because of some syndromic association as a limitation and all that, that is one thing. And we avoid doing the, and in fact, we have stopped doing no ERGs under general anesthesia, because that itself can be a confounding factor.
Okay. Thank you.
I'm really sorry. I just went to discuss with the OBSC group for the forthcoming midterm conference. I'm really sorry. So, Dr. Sophia, are you here? Dr. Sophia?
Yes, I'm here.
Okay, you can give vote of thanks. You are institutional head. You are heading Bokaro General Hospital, and DNB courses came much after later to other institutions. You were first among the those institutions who have PG teaching. How did you like the Fishbowl? How did you like the Retina CME by the national stalwarts? Do you think it was very how useful was it? Please give the vote of thanks and your opinion also. Dr. Kashyap, are you here?
First, I would like to thank all the PG students who actively participated, and it was an excellent presentation from both the students. And such nice questions were coming from the PG students. They were really interested and they had read the topic. And the discussion was also done by the panelists, senior Dr. Sugneshwari, Dr. Pratyush, and Dr. Punachand. They almost cleared every doubt, and all the questions were answered very well. And this was a very interactive session. So next time when these students join, they'll know what to do, and they will have more active participation. And thank you all from on behalf of Jharkhand Ophthalmological Society. Thank you so much.
Thank you so much. Thank you so much, and especially for staying so long. For staying so long.
Yes,
I'm
yes,
really thankful.
so long.
And for to Dr. Sugneshwari, Dr. Pratyusha, Dr. Subina, Dr. Purna. Actually, I added Dr. Purna's name because there was a talk on electrophysiology. So this case involved electrophysiology. So though he was not very well versed with the fishbowl, but I was also thinking, what is this fishbowl? But I really found it very interesting. Any postgraduate student, Ujjwal, तुमको कैसा लगा? बताओ. How did you like this fishbowl?
Ma'am, I like the fishbowl.
इसमें तुमको क्या अच्छा लगा?
Ma'am, the presentation was very comprehensive. Everyone was participating. I also wish to add in a typical RP to families to be counseled is very important, because the symptoms they don't get to know na matlab the peripheral wheel loss, nyctalopia, these are very the family members don't get to, so regular counseling follow up is very important.
नहीं वो मैं समझ गई. ये फिश बोल का कॉन्सेप्ट तुम लोग को कैसा? गगनदीप, ये
Yes, ma'am.
तुम लोग को यहाँ I can see someone but उसका नाम नहीं दिख रहा है. Zoom user. Then they have not written their name, so but their camera is on. So this concept you like, na? Actually, I am getting a lot of calls, Sugneshwari. When we invite you guys, you please take your time out. You have taken a lot of time out for our postgraduate students. And best part, nobody is an election campaigner. Everybody has done academics for our postgraduate students. So thank you so much. Seema, कैसा लगा? अच्छा लगा? Thank you.
It was very nice. I really like the concept. इस तरीके का discussion बहुत मतलब
next time करेंगे. Next time करेंगे. And now I'm leaving. And thank you all because हमारा वो चल रहा है बहुत ज़्यादा discussion अभी.
Thank you and good night.
Thank you. Good night.
Thank you, ma'am. Good night, ma'am.
Good night.